So I'm going to introduce our last speaker for this session, and this is Robert Lees. Robert is also a trainee consultant clinical scientist working at Barnsley NHSP, again in red cell immunohematology. He's got 20 years of experience working there. Special interest in fetal-maternal hemorrhage, IgA deficiency, and really luckily for this topic, anything involving rare blood groups and antibodies. So you're very well suited to deliver this next session. So you're going to talk to us about SOS. Thank you very much.
Yes. Yeah, good afternoon, everybody, and thank you to the organisers for the invite. As you can tell, I'm not East Midlands born and bred. I'm Barnsley, Yorkshire born and bred. This was a sample that we came across whilst we still had a Sheffield RCI lab. So this is a sample from a few years ago, but it's still a really interesting case. I want to put some credit on the slides to Dr. Ruth Witherall from Nottingham. She at the time helped us out greatly with the patient. It was her patient, but she provided us with a lot of the background clinical information that I'm going to share with you now. So this patient story started a long time before we ever saw him in RCI. So this was a guy with from the Nottingham region. He's Kurdish born. He had a very limited English language capability. He was unemployed and smoked, drank, lived in a hostel, had angina, and started having seizures and blackouts. So already a complicated patient to deal with. So because of the blackouts, he was referred to neurology. So this was quite a while ago in March 2018, and he was referred because he was having blackouts. So as part of the workup, the chap had a head MRI, and they found an incidental finding of bilateral neck. Lymph nodes were unusual, so they were slightly concerned about that. He got a history of night sweats, and he'd noticed himself that he'd started losing weight over the recent months. So on physical examination, they noticed that this guy had got quite widespread lymph node complications. They were all enlarged, they were all unusual. So obviously they were quite concerned, and they sent the chap for a PET scan. His HB was 140, white cell 6.1, platelets 250. So hematology-wise, not too bad, but they sent him for a PET scan. And I've written positron emission tomography because I could never remember what PET stood for, so there it is at the top. But this is sort of a scan that's looking for high cell turnover, high cell metabolism areas within the body. So unusually high cell growth, cell regeneration, if you like. So you can see from the PET scans, particularly around the lymph nodes here, you've got a high level of cellular activity. So this was obviously a concern at this time. Unfortunately, the patient was diagnosed with T-cell acute leukemia. He had lymph node and bone biopsies that showed a large amount of blasts. So these are immature cells, and cytogenetics confirmed this finding. So TALL is a very aggressive disease. The 5-year overall survival is 50%. And because of this, the gentleman was referred and admitted to chemotherapy treatment. So this is sort of, again, a snapshot of his treatment during the time he was in hospital. So phase 1 induction, phase 2 induction, and then post-induction. And the line along the bottom is his hemoglobin. As you can see, it dropped during induction, as you would expect, to just under 80 grams per litre, but not too bad. But to obviously make him feel a little bit more comfortable, he was transfused. So he's had 8 units of B pos, 2 O pos, and also some platelets. So during this time, he was antibody screen negative, no issues with the ABO group. Units were cross-match compatible. Now, for reasons that no one has been able to work out, on the day of his discharge from hospital, the clinicians decided to do a group and save on this patient, even though he was literally about to walk out of the door. And these were the results that the hospital lab obtained. So this is obviously very different to the patient's results throughout his stay in hospital, throughout his entire treatment regime, really. So again, like Nikki and Sarah have explained, this is the antibody ID panel, but pretty much you can see that from the results here, this, if you can just see, is the IAT result, and this is the enzyme result. You've got a pan-reactive antibody, you've also got a positive auto. So this is at the point where the hospital lab said, there's nothing we can do with that, we can't exclude any antibodies, we need to send that to RCI to have a look at, which is what we did. Unfortunately, we got exactly the same results that the hospital got. We've got a pan-reactive IAT, got a very strongly pan-reactive enzyme, but when we tried to perform the absorptions, as Nikki and Sarah have described, this is to remove autoantibody, nothing happened. The strength of the reactivity didn't move, didn't reduce, or didn't clear at all. We did try some DTT cells in case he was one of these patients that's on DARA or isatuximab or a CD38 monoclonal antibody, and it's not in his notes, or we're not aware of that. That was positive as well. So we know it's not that involvement. So something strange is going on with this patient's serology. It's very unusual for the antibody not to be removed by the absorption cells. Usually happens when you've got a very, very strong autoantibody. In this case, we were slightly suspicious because if you notice, the auto strength is noticeably weaker than the panel strength, and the DAT was literally only positive 2+ for IgG. So we're not talking about a 4+, 5+ pan-reactive autoantibody that we do see sometimes that do take some absorptions to remove. This wasn't a particularly strongly positive DAT. So we're starting to get a little bit suspicious that something else might be going on here other than an autoantibody. So what else could it be? What else can we do in these situations? Again, this has sort of already been gone over already, but rule out the obvious. Is it something like an anti-HI? Is this an antibody that forms against people that lack the H substance? So pretty much all your group O red cells are very strongly positive for H substance. All your reagent cells are group O. Is that why it's reacting? If we were to try some group B cells, would they be negative? They lack a lot of the H antigen and stuff like that. So we do that. We look for anti-HI. It wasn't that. Again, what we've talked about in both previous talks is we can do the full red cell phenotype and or genotype. So obviously this patient's DAT pos, we're probably better off doing a genotype due to the DAT pos interference in the monoclonal reagents. So we can do a full phenotype. We can try something called a PEG absorption. So this is where we add polyethylene glycol to the absorption cells. It makes them more antigen positive. It allows them to attach more autoantibody and try and remove it from the plasma. So we can try that. That didn't work. Is it drug induced, or is it a drug that this patient's been given? Have they been given massive doses of IVIG that we don't know about, or that's we've not been told about? Because that might be the reason why we just can't remove this vast amount of antibody, apparently. But the one thing we've nearly always got in the back of our mind is, well, it can't be anything rare, because if it's something rare, it will absorb out. Those red cells that we're using to absorb must be antigen positive for any rare red cell phenotype. So if they're antigen positive and it was a rare antibody, it must absorb out. However, if you think back to Sarah's last topic, that's not always the case. So we obviously, as part of the test, we do an ABO and RH phenotype on the automation. So we performed the ABO group. That came out as a group B positive. No discrepancy, no additional reactions, a nice group B forward group, and you've got anti-E in your reverse group. Your B cells are negative, so it looks like a straightforward B positive. Part of a new investigation, we run a full RHK phenotype. That came out as discrepant. that actually got rejected from the machine because there was no apparent results in the wells. However, that was a correct result. We repeated the RH phenotype and it repeated exactly the same. So initially it was rejected manually by the member of staff saying, actually, that's not sampled, that phenotype for some reason, the automation's not sampled those red cells. But if you look, it has sampled those red cells. All the red cells are at the bottom of the wells, so they're antigen negative for all those other RH antigens. So this immediately started ringing alarm bells, particularly for some of the senior members of staff in RCI that have potentially seen this issue before. So as my colleagues have previously mentioned, we've got a selection of antigen negative rare red cells within RCI that we can use. So we set this patient's plasma up against 2 RH null cells. So RH null, and I'll come on to that in a moment, is a complete absence of any RH antigen, so the D, the C, and the E. And these were the only 2 cells that were compatible. Out of everything that we've tested, these were the only 2 cells that were compatible against this patient's plasma. So now we're thinking we're in big trouble. So, quick, and I mean quick, reminder of RH genetics. So RH are coded by 2 separate genes. One gene does the D, and the other gene does the C and the E. So we've got two different genes on the same chromosome. One does RHD, one does RHC and E. If you've got no RHD gene, you are an RHD negative. So the D is not expressed, you are RHD negative. So what we're looking at potentially is a really rare RH phenotype on this patient and the corresponding antibody. So if you're an RH null, you lack both parts of the gene. So you don't express any D and you don't express any C or E antigen. So you're a complete amorph, if you like, you're a complete RH null. You've got no RH phenotype there. We know this is not the case for this patient because he's testing as a normal D positive individual. His D typing on his ABO group is absolutely fine. He's a B positive. So what we now suspect, or what we now know, is that actually this patient is what's called a -D- or a -double-. So this patient has a fully working intact RHD gene, but has a complete absence of the CE part of the gene. That's not being expressed for different reasons, but generally, as Nick has explained, singular nucleotide polymorphisms can put a stop code on in this gene and stop any of the antigens being expressed. So what this means is that this patient lacks any of the RH antigens. So they're big C neg, little c neg, big E neg, little e neg, in principle. What this means is that basically this patient, after they've been transfused any normal, inverted commas, red cells, they will form an antibody. And the antibody is called anti-RH17 or anti-HRO. And it's formed in patients that are -D- phenotypes. So it's a clinically significant antibody. The way I think of it is it's an anti-big C, anti-little c, anti-big E, and anti-little e, all combined together. So you try and think of an RH phenotype that would be suitable to transfuse this patient, and there isn't one because there will be big C, little c, big E, and or little e positive. So you're giving this patient antigen positive red cells. The antibody that they've got will detect and react against anything that is positive for big C, little c, big E, and or little e. So added complications was that the patient was a group B. So that immediately limits your searches to group B or group O. We had done phenotyping. We couldn't exclude anti-big S and we still couldn't exclude anti-Duffy B. That was ourselves, no BGRL. So, we know that there's potentially this extremely rare red cell alloantibody, but actually we can't exclude some of the common clinically significant antibodies either. Well, no need to panic, the clinical team said. They said it'll be fine, don't worry, don't rush. You've got 24 to 48 hours before we need to transfuse. So, HB62. Great. It doesn't sound like it's particularly great situation for this gentleman to be in. So we start looking at other options. Have you got any siblings? Yes, he's got a sibling who still lives at the top of Iraq and who's got heart complications and has no way of getting to the UK. So yes and no. that option's no good to us. We needed to check NFBB UK. They got one unit. Amazing. They've got one unit that's suitable. Oh no, it's a group A. So that's no use. So then we start looking at the international registry for donors. So this is an international registry for rare blood donors. So we found a donor in Spain and we found a donor in Japan. So we managed to get a unit of blood donated in Japan and sent over to us within a few days. It wasn't within the 24 to 48 hours that's required at the top, just so you're aware. So this unit was sent to us from the Japanese Blood Transfusion Service, and it arrived in our hospital services in Sheffield like this, with a handwritten note, handwritten label stuck onto it saying OPOS -D- and the expiry date. Correct, whoever's put the... So that's the face that our quality department pulled when they saw that unit. But that is the only unit pretty much in the world that is suitable for this patient. So we spent a lot of time in the quality manager's office. We spent a lot of time speaking to the people in Pulse, because obviously we couldn't issue this unit through our usual Pulse blood transfusion software, because none of the barcodes would match, none of the ISBT numbers were compatible. So this was a real issue at this point. But I always love showing that photo. I always tell people that we had a blood donation sent with a handwritten label on, and they go, "No, you didn't." And then hence why I took the photograph of this unit. So no one obviously believes me. But obviously you're talking incredibly rare blood for this patient. So as Nikki said, we will do an RCI report. We'll send the sample off to IBGRL. This came back pretty much as what I've said. Patient's got an anti-HRO, RH17, weekly positive DAT, unable to exclude Big S and Duffy B, and the patient can really only be transfused -D- blood or RH0 blood. So actually, the patient managed, without having that unit of red cells, they actually managed to control his condition. They managed to not transfuse him, which is good, and that's fine. But the question was then asked to us, and that's the bomb going off in Nottingham City Blood Bank, if he has a bleed. What do we do if he bleeds? Well, the flippant answer is hope he bleeds a lot, because if he's bleeding a lot, you can pretty much put anything in, and whatever goes in is going to come straight back out again. So the chances of him having a reaction are less. What you also need to bear in mind is don't expect and don't order, because we know somebody they will write 4 units of -D- please by 7 a.m. tomorrow morning. Don't do that, because you're not going to get any -D- or RH0 blood for this patient. So it's, again, as we mentioned before, communication. So usually in RCI, as my 2 colleagues have mentioned, we have an option A, which is the ideal unit, and then we have a sliding scale of what to give next. So in general, if we don't know what an antibody is, the basic advice is provide RH and K matched. But what RH and K matched? Would anybody like to put in chat what RH and K matched they would give if they couldn't get a -D- or RH0, which is the worst or best RH phenotype to select for this gentleman if we can't get any -D- or RH0? So that's sometimes where the standard advice is not always the best. Obviously, we need to try and mitigate any transfusion reaction. We need to try and dampen down this gentleman's immune system, but bearing in mind the condition he's got and things like that. So IVIG and steroids are an option. And obviously we give advice to monitor for a delayed transfusion reaction. I mean, I don't think personally it would be very delayed if you were to transfuse this gentleman normal red cells, but luckily we never found that out. And again, Joel get very excited. I'm going to mention PBM because in this case, this patient is pretty much an untransfusable patient. So you've got to use the PBM measures. So we looked at everything. Autologous donation wasn't appropriate in this. We've looked at siblings. We looked at rituximab to dampen down his immune system and modulate that immune response. And we can look at things like plasmapheresis to try and reduce the level of antibody pre-transfusion. Doesn't happen very often. It's not something that we usually consider, but when you've got a patient that is pretty much untransfusable, it's something that potentially we need to look at. And again, patient blood management, reduce blood loss, look at alternatives, manage this gentleman's anemia, manage his symptoms, which is what the hospital did really well. Again, Dr. Ruth Weatherall's not on the call, I don't think, but this was all the sort of things that they put in place to actually prevent this patient being transfused, or to stop this patient being transfused. Because with the unit that we got, yes, we could give him that single unit, but if that wasn't enough, we're giving somebody antigen positive red cells, and actually if you can avoid that, that is the best treatment for the patient, is to avoid that transfusion. So this was a really complicated case, and I'm glad both my colleagues have mentioned this, and I'm glad you guys have picked up, Joe and colleagues have picked up on this from the first two things. Oh, just to mention, one of the alternatives was asking if the gentleman would like to go and live in Japan. So I don't think he took us up on that offer, but that would be his best bet if he wanted to get any blood. He's far more likely to get a -D- or an RH0 red cell unit from a Japanese donor than anywhere else currently. So yeah, we did offer him the suggestion that he might want to move to Japan, but I don't think he took us up on that offer, unfortunately. Again, it's a team effort. And I know my colleagues have said this before, but we get these really difficult cases that come into us. We see a snapshot at the end, in the middle, where we do the testing, we identify the antibody, and we try and source blood. But actually, there's a massive team of people inside and outside of NHSBT that all are trying the hardest to manage this patient and protect this patient and give them the best care possible. So you've got your MDTs, like Nikki mentioned, you've got the frozen bank, you've got donor testing that are testing the donations, but you've also got the rare donor team. So somebody asked, can you call donors up? We will have a panel of donors that are sitting at home, like International Rescue, waiting for the phone call. Can you come and donate your VEL negative? And they'll, 99 times out of 100, they'll come and donate a unit for a particular patient. So they're amazing. The team that organised that are amazing. I'm sure my colleagues would agree. And obviously then there's all the clinical input. There's the input from you guys in PBM. What can we do? Can we have a conversation to try and reduce blood loss? Can we have a conversation about actually, can we do something else other than transfusing? And there's a massive amount. Obviously, there's BGRL that do the rare testing. They can do the molecular types and everything from literally getting the blood down to you guys via hospital services from Liverpool to an RCI lab, from RCI lab to your blood bank. So it's a massive team effort. So I always like showing this slide because I think sometimes we all concentrate, and we're guilty of it in RCI, of doing our bit, and then actually we send the blood out, and that's that, we're done. But actually, there's a massive team that's helping sort out these really complicated patients. So I hope mine and my colleagues' talks have reiterated that, really. And that's all I've got to say on Mr. -D-. Any questions?
Thank you, Rob. That was really interesting. There's some questions and comments in the chat. I think we've got Cherry, Dr. Cherry Chang on the call from Nottingham, and she's put, she could tell you why there's a group in Save Done, as they are routinely scheduled 2 to 3 times a week on haematology in patients, whether or not they need a transfusion. I think that was really early on in the chat, wasn't it?
Yes, and it's funny because we did wonder that, and we thought, what were the chances of that coming up pan-reactive on that day? So our theory is, and hopefully Cherry might agree, is that obviously the patient's been on heavy immunosuppression during that period. He'd had 10 units of red cells, and A, not reacted, and B, not formed an antibody until we assume the immunosuppression started dropping off. We think it's quite lucky that he had that sample. I was being flippant on why did they do it, but actually if we'd have not had that final sample, he would have never known that he was a -D- individual and got a really rare blood type, because he'd been antibody screen negative up to that point. So yeah.
Interesting. Next question. What was the explanation of being D-pos initially? Has it changed with the chemotherapy?
D-pos. So
Yeah.
the gentleman was always D positive because he's got the D gene. He probably wouldn't have had an extended RHK phenotype done at the hospital as part of that. They would have just gone. He would go through life testing as a normal B positive. It's only when you look for the rest of the RH antigens, the big C, the little c, the big E, and the little e, that it came out as a null. Joe, you will remember Phil. It was Phil Wright that leapt out of his chair and said, "Oh my!" I know. So it was Phil that picked up the fact that the RH phenotype was the only clue really that got us down the path of
it's a really exciting find, though, isn't it?
It is. I've heard of one other one, I think, from the London area since that's been a -D-.
Interesting. Next question. Is there a risk by accepting donations from abroad? Do they have the same criteria for accepting blood donors as the UK?
That's a really good question. I would like to say yes, but I mean, I'm assuming that would have been sort of discussed and there would have been a clinical risk assessment done on that. You would assume so, but they possibly wouldn't do all the testing that we do. They might do it by a different technology. So I would have to look at that, but that would be a caveat. That would be a risk assessment that's done, and they would have to accept that risk. You would think, yeah. So somebody's put European Union countries certainly do. So yeah, you would think so, but obviously internationally, you would think that if they were part of an international donor register, there would have to be a minimum requirement for blood donations. But it's a very good question, that.
Yeah, I suppose you're way up. I mean, just looking at the bag with the handwritten OPOS and dash on it.
Again, Joe, you know who the quality manager would be at Sheffield at that time, and Mr. Burns, and you can imagine the conversation that we had trying to get that out of the door and through Pulse. Yes.
A comment here from Falguni. Thank you to all the speakers. As an anaesthetist, these talks have highlighted the detective work that happens in our labs. Very reassuring as well to see the effort that it's taken to provide the best possible match. I shall be highlighting to my team the importance of adequate notice, the involvement of multidisciplinary teams and good communication. And I think that's gone all the way through the 3 talks, hasn't it?
Yeah, no, that's really good.
And Cherry's put a comment. The haematology consultant wasn't terribly concerned about patient needing blood as he was young, and the lab weren't worried about the hemorrhage situation. So ALL transfusion is much less myelosuppressive, would have been difficult, impossible to treat if AML.
Yeah.
And then some thank yous. Very interesting talk. Thank you, everybody. I'll hand you back to Jan.
Again, just to say a massive thank you, because it's all been desperately really interesting. I think, I don't know about wearing white coats, you guys in the labs, but I wonder if deerstalker hats would be a more suitable option for you to all wear with the detective work that seems to go on in the background. So yeah, really good. Thank you everybody for speaking. Thanks, Debs, for your support, and Joe. Thank you everybody for attending and for your support. It's great. But thanks everybody. Really good session.
Thank you.